and we're back. We are back. So I wanted to show you the AI video from this patient. So here we go. 3, 2, 1.
Over the last 6 months, I've been having trouble sleeping. I wake up sweaty in the middle of the night, and my moods are all over the place. My periods are barely showing up now. I just want to know what to expect. And
wow, interesting sound at the end there, but she has perimenopausal symptoms. So this is from menopause. That was from our last question there. So now we're on to this new question. Oh, excuse me, this was the new question. So let's start that over. I thought this was still on the last question, but it looks like this is actually on the new questions. That's great. So we'll go back to this one. All right, everybody, here we go. Here is our patient. A 52-year-old woman visits her primary care physician with complaints of recurrent episodes of flushing, wheezing, watery diarrhea. She's gained 10 pounds over that period. Her medical history is significant for hypertension. Actually, I think it was for that last patient. Actually, let's watch it together and figure it out.
over the last 6 months, I've been having trouble sleeping. I wake up sweaty in the middle of the night, and my moods are all over the place. My periods are barely showing up now. I just want to know what to expect. And
Yeah, so that's definitely menopause. Absolutely. So here's our next question. All right. So, a 52-year-old woman visits her primary care physician, complains of recurrent episodes of flushing, wheezing, watery diarrhea. She's also gained 10 pounds over that period. Her medical history is significant for hypertension, which is currently managed with lisinopril. Her vital signs are as follows: temperature is at 98.2, heart rate is at 80 beats per minute, respiratory rate is at 16, blood pressure is 150 over 92. All right, physical examination reveals a prominent systolic murmur heard best at the right upper sternal border and bilateral wheezing. Lab studies show mild hypokalemia and serum serotonin is elevated. An ultrasound of the abdomen reveals multiple hypoechoic lesions of the liver. Which of the following substances is most likely elevated? Okay, a lot to think about here. So there's a triad that we have to be aware of. There's the flushing, wheezing, and diarrhea. Flushing, wheezing, diarrhea. That is a triad for carcinoid syndrome. There's elevated serum serotonin, and that is going to confirm that we have this neuroendocrine tumor here. There's liver metastasis. That's a very key clue because that confirms serotonin secreting neuroendocrine tumor. And also there's liver metastasis, right? Um, and that's really important because liver is normally going to metabolize serotonin. And so you have systemic symptoms only after the metastasis bypasses the hepatic metabolism. And there's also systolic murmurs at the right upper sternal border. Right upper sternal border, that's tricuspid, right? Tricuspid is the right upper sternal border. So tricuspid regurgitation, or maybe it could be pulmonic stenosis due to a serotonin-induced endocardial fibrosis. And the urinary marker, that's the breakdown product of serotonin, is 5-HIAA. And so that's the reason it's going to be C for our answer. Our answer is C, right there. And so these carcinoid tumors, they are slow-growing neuroendocrine tumors that secrete serotonin and other vasoactive amines. You get the flushing, that's from the serotonin and also bradykinin vasodilation. You get the wheezing. I'm just going to turn off that light. It's a little bit too bright for me. I'll turn it down a smidge. Wheezing is from the bronchoconstriction, and that occurs because of the serotonin as well. Diarrhea is the increased GI motility and secretion, and the right-sided valvular lesions is serotonin-induced fibrosis because the lungs inactivate serotonin before it reaches the left heart. All right. So the flushing, diarrhea, wheezing, all that stuff is the serotonin is carcinoid syndrome. Carcinoid. All right, let's look at these metanephrines. That's the breakdown of epinephrine and norepinephrine. That's seen in pheochromocytoma. So that's not the right answer. Venomandelic acid. Well, that's the end product of catecholamine metabolism. So also pheochromocytoma. Or also, for this, you could be thinking of a neuroblastoma as well. Cortisol. That's increased in Cushing's, and there's not going to be increased in flushing or diarrhea. Homovanillic acid. Homovanillic acid, that's HVA, that's a dopamine metabolite. And so you'd see that in neuroblastoma or Parkinson's drug monitoring would be the associations for step one on that. So carcinoid tumors, they originate from the neuroendocrine cells in the enterochromaffin, the enterochromaffin cells of the GI tract, especially in the small intestine. And so they secrete serotonin, bradykinin, histamine, and also prostaglandins. And so normally the liver metabolizes all that stuff, but these people are going to be asymptomatic until finally you get that hepatic metastasis, and then the serotonin reaches the systemic circulation. And you get that flushing, diarrhea, wheezing, that carcinoid triad, tricuspid, and also pulmonic valvular lesions. That's right-sided fibrosis caused by that serotonin, and also the elevated 5-HIAA diagnostic urinary marker. All right, so just look out for that and know about the liver metastases, and you should be good for this question. All right, so elevated urine 5 high acid indicates diagnosis of carcinoid syndrome. Now let's see if this is loaded yet.
My face will just get hot, all of a sudden red, like it's on fire. Happens a few times a week now. And I keep wheezing like this, just walking up the stairs sets it off. over the last sudden red, like it's on fire.
All right. So here is our patient, as you can see. I'm going to click play and we'll watch their presentation.
My face will just get hot all of a sudden.
1 second.
Red, like it's my face will just get hot all of a sudden, red, like it's on fire. Happens a few times a week now. And I keep wheezing like this, just walking up the stairs sets it off.
All right. So there's our patient. And as you can see, she's got that wheezing. She's got that carcinoid presentation. We'll listen to it once more.
My face will just get hot all of a sudden, red, like it's on fire. Happens a few times a week now. And I keep wheezing like this, just walking up the stairs sets it off.
Okay. So this is really interesting. Let's talk about the symptoms that she discussed. The hot face. So serotonin and vasoactive substances are going to be releasing serotonin, histamine, and bradykinin, and also prostaglandins. These are vasodilators, and they all increase the blood flow to the skin, especially the face, and also your neck and your upper chest area. And it causes episodic flushing, and it feels hot, and it looks red. And so that's what this patient was talking about. Why is she talking about the wheezing, though? Well, that's going to be serotonin and bronchoconstriction. So serotonin and other mediators, like histamine and bradykinin as well, they're pro-inflammatory agents in the lungs. And so they cause bronchial smooth muscle constriction, which is similar to asthma. And that narrows those airways and it causes the wheezing, the shortness of breath, as she said, when she's walking up the stairs. So walking up the stairs, that's physical exertion. And so the exertion activates the sympathetic nervous system, and that increases the blood flow, the gut movement, and the metabolic demand. That stimulates the carcinoid tumor to release more serotonin and other vasoactive substances, which then causes, as we discussed, the flushing and also the bronchospasms, and even maybe diarrhea shortly after. So the hot face, vasodilation from serotonin and also histamine, and then the wheezing is from bronchoconstriction from serotonin and also bradykinin. And this is triggered by exertion because it stimulates that tumor secretion.
That's more like.
Hey, Ahmed, how's it going? Do this live in Zoom. That is a great idea. Also, I'm realizing I still have that YouTube API bug, so now I have to disable the chat window because if not, it's going to go on forever and ever. Let me actually fix that chat right now. But that's a great idea. Actually, this Saturday we have our first Zoom session. There's just a lot of debugging to do. I want to go a lot quicker, but I'm building all this stuff live. Browser. You specify one lecture and solve random MBME. Yeah, that sounds great. Honestly, I do a lot of these live streams. Let me just try to fix this problem real quick. Yeah, I do a lot of these live streams just because it's like the time that I have to work on this, you know? But eventually, when I have a little bit more time and all this stuff is polished, I'd really love to do that. Okay, here we go. But that is a really great suggestion. I really appreciate you for giving me that suggestion. I can't tell you how much it helps. So many good ideas are coming that I never would have thought of. So I really appreciate that, Ahmed. All right, here we go. 30-year-old man is found unconscious in his apartment and brought to the emergency department by paramedics. His roommate reports the patient has been a binge drinker. And upon admission, the patient has difficulty to arouse and does not respond to verbal stimuli. Vitals are as follows. Temperature is at 36.7, 98.1. Blood pressure is 110/70. Heart rate is 80. Respiratory rate is at 14. Lab tests reveal blood glucose is at 40. Wow, that's low. and elevated serum lactate. His consciousness improves significantly after administration with dextrose. Which of the following explains the cause of hypoglycemia? Okay, there are your answer choices that you get to choose from. What do you guys think? So the binge drinking and the fasting, that is a big setup for alcohol-induced hypoglycemia. And he has elevated serum lactate, would mean lactic acidosis, and that's going to be the pyruvate, which is going to be diverted from the gluconeogenesis. And also, there's improvement with IV dextrose that confirms that the symptoms are due to low glucose availability, and alcohol metabolism that produces excess NADH. And NADH is going to alter the normal hepatic metabolism. So there's too much NADH, there's not enough glucose, and you just kind of have to know that pathway. Basically, alcohol dehydrogenase and aldehyde dehydrogenase are going to generate NADH in the liver. So you get a lot of NADH whenever you drink alcohol. And so you have a high NADH to NAD plus ratio, and that pushes pyruvate. That pushes pyruvate into lactate and oxalacetate, which then gets pushed to malate, and that blocks the key gluconeogenic steps. And so even though glycogen is gone, right, he's got a 24-hour fasting, gluconeogenesis just can't kick in. And that is the cause of hypoglycemia. So ethanol metabolism generates NADH, which impairs gluconeogenesis by shunting pyruvate to lactate and oxalacetate to malate. During prolonged fasting, so like if you don't have food for about 48 hours, 2 days, glycogen is going to be depleted. And then the body is going to depend on gluconeogenesis to maintain the glucose. And so impairment is going to lead to severe hypoglycemia and lactic acidosis. All right, let's look at these answer choices. Impaired gluconeogenesis. So that's the opposite of what happens here. So gluconeogenesis is blocked, is not increased, right? Definitely not going to be increased. It's going to be blocked. How about decreased pyruvate conversion to acetyl-CoA? Well, that would impair the TCA cycle, but that doesn't explain lactic acidosis or hypoglycemia. How about overproduction of insulin? Hey, Moise, how you doing? Good to see you. Overproduction of insulin. No signs of insulinoma or sulfonylurea overdose, and so this is not associated with alcohol or fasting. Decreased glycogen breakdown. So that would explain early fasting hypoglycemia, but glycogen stores are gone after 24 hours of fasting, and the issue is with gluconeogenesis, not glycogenolysis. So in early fasting, the body uses glycogenolysis. After 24 hours, they rely on gluconeogenesis. Now let's look at our patient, shall we? Wait, let's do our bottom line first. So binge drinking causes hypoglycemia by increasing NADH, which inhibits gluconeogenesis. Okay, so now check this out. Oh, come on. I thought it was going to work. So close. So close, guys. Oh, it did work. Nice. Watch this. Ready? 3, 2, 1. Let's listen to our patient, shall we?
Feel better.
There he is. There's your patient, guys. I love this because it's interactive. You can kind of pretend that you're there. This is your patient. You see that there's alcoholic hypoglycemia after binging and no food. There's NADH excess that's pushing pyruvate to lactate and lactic acidosis, oxalacetate to malate, and the TCA cycle and gluconeogenesis is blocked. And so you get the confusion, the coma, the tremor, the seizure, the resolve, and all that is resolved with glucose. In this question, they give them dextrose, right? So there are some similar conditions, like in infants of alcoholics or malnourished patients as well. But it's that ethanol, which is metabolized by ADH and also aldehyde dehydrogenase, and that generates NADH. And then it gives you a high ratio, which then causes lactic acidosis, converting oxaloacetate to malase, and that inhibits or decreases gluconeogenesis. Okay? So there's the bottom line, which we've talked about. Now on to our next question. All right, here we go. So a 45-year-old woman presents to the emergency department with fever, fatigue, and widespread rash 2 weeks after receiving a liver transplant from an unrelated donor. On examination, there's diffuse erythematic maculopapular rash on her chest, back, and limbs. Lab tests reveal elevated liver enzymes and mild elevation of creatinine. Skin biopsy is performed, and histology reveals a dense lymphocytic infiltrate at the dermal epidermal junction, which process is most likely occurring at the keratinocytes in this junction. All right. So this is 2 weeks after the transplant. And so this time frame is going to be fitting acute graft versus host disease. There's also diffuse erythematous maculopapular rash and with elevated LFTs and renal involvement. And so that's a systemic immune attack by the donor T cells against the host tissues. There's also lymphocytic infiltrate at the epidermal junction. And that's going to be like a lymphocytic would be cytotoxic T cell mediated injury. And the keratinocyte damage is going to be a hallmark of apoptosis, not necessarily necrosis. So let's talk about graft versus host disease for a second. The donor T lymphocytes from the graft. The donor T lymphocytes from the graft recognize the host cells as foreign, and then they attack the rapidly dividing cells. So, like skin, liver, and the GI tract. And so the injury is usually self-mediated or cell-mediated. And so if it's cell-mediated, this is going to be a type 4 hypersensitivity reaction, and it occurs via apoptosis. So basically, the host cells undergo apoptosis by cytotoxic T cells and the cytokines, so interferon gamma, TNF alpha. And in graft versus host disease, the donor T cells mount an immune response against the host epithelial cells. Let's look at the other answers here. Hypertrophy is a silly answer. That's increased cell size due to like stress and like that. Hyperplasia, that's increase the cell numbers, not T cell stuff there. Metaplasia is reversible cell type changes. So think like squamous metaplasia in smokers, not death, right? Necrosis, that's uncontrolled inflammatory cell death. Graft versus host disease shows controlled apoptosis, not necrosis. So here's our bottom line. Apoptosis of the keratinocytes at the epidermal junction indicates acute graft versus host disease in post liver transplant patients. Now let's visit our patient and we'll see. Pretend you guys are walking into the ER and you see this. Ooh, hasn't finished loading yet.
Erythema. 2 weeks after her liver transplant, she develops fever and a widespread erythematous rash. Lab work shows elevated liver enzymes and creatinine. Skin biopsy demonstrates.
All right, here's our patient. Let's check it out. They're going to explain to us this mechanism. And just to kind of refresh our brains here, we have a 45-year-old woman presenting to the emergency department. She has fever, fatigue, widespread rash 2 weeks after receiving a liver transplant. So let's check this out. So ready? We're going to say hi to our patient and we'll see what this video entails.
2 weeks after her liver transplant, she develops fever and a widespread erythematous rash. Lab work shows elevated liver enzymes and creatinine. Skin biopsy demonstrates dense lymphocytes at the dermal epidermal junction.
All right, so there it is. And you have to be confident in what exactly she's experiencing and why she has those histological presentations. So she has that rash, because of graft versus host disease. She has that lymphocytic infiltrate at the dermal epidermal junction, and that's going to be interface dermatitis. And she has the elevated LFTs and the post-transplant stuff. There's just multi-organ graft versus host disease. And the basal keratinocyte apoptosis, that's where you have to know the hallmark mechanism. Hey, Chess Noob. How's it going? Yeah, I'm streaming on like 3 different platforms and I can't see. A lot of things are going crazy right now, but I'm back. All right, here's the next question. So we have a 45-year-old man. Oh yeah, why it got shut down? Yeah, it got shut down because yesterday we were covering endocrine reproductive physiology, and as you can see, I have all these AI images. And so we were doing a question on varicocele, where you have the blood pooling in like the right scrotum, and then I thought that the AI image for pollinations would have prohibited like, or just wouldn't have generated anything that looks remotely like nudity, but I guess it did. So literally, we're doing a question about venous anatomy of the veins um, of the lower part of your body, and then an AI generated an image of frontal nudity, and so they banned the account for one day. So then I just went into the code and I tweaked everything, because then I'm realizing, yeah, like it's just interesting. We're in medical school, and so it's like you see every day. You're studying reproductive endocrinology, and so it's like you don't think twice about it. But anyways, we changed all of the filters, so everything should be all good to go. And plus, I've got some new mechanisms that I've hard coded in to make sure that doesn't happen. But like, it wasn't even anything like I was crazy because I was streaming on 4 platforms, and Twitch was the only one that mentioned anything. All right, here we go. But yeah, very interesting. And then I had to reconfigure everything to YouTube and then back to Twitch. But here we are again with a couple of weird difficulties, but alas. All right. I'm excited to do the streamer chess thing too, whenever that happens. Okay. So a 45-year-old man presents to the clinic with complaints of increasing fatigue and frequent infections the past 2 months. Lab tests reveal a white blood cell count of 95K with a predominance of immature myeloid cells. A diagnosis of chronic myelogenous leukemia is expected, and the oncologist discusses treatment options, including a drug that targets BCR-ABL. This treatment is expected to interfere with which of the following aspects of the cancer cell biology? Okay, so 95K with immature myeloid cells, that's CML. It's a myeloproliferative neoplasm. The BCR ABL thing, that tyrosine kinase, that's the fusion protein that's formed by the T9 translocation, the 22, the Philadelphia chromosome. And what happens here is there's a constitutive signal transduction. Yep, so there's this fusion gene that creates the constitutively active tyrosine kinase, which drives the unchecked cell growth. All right, so they have chronic myelogenous leukemia, and now you guys can see the lab values are actually going to be accurate. All right, Chess Noob, thanks so much for popping in. Good to see you. We'll have to play chess sometime. So mitochondrial apoptosis, intrinsic cell death. Apoptosis would occur downstream, but not the primary target in CML. DNA double-strand repair, BRCA homologous recombination involved in other cancers like breast and ovarian. Okay, so basically what's happening here is there's just a genetic problem where your cells just can't stop multiplying. And so we have a 45-year-old, they got fatigue, infections, and a white blood cell count of 90K. So this is chronic myelogenous leukemia. And what fuels this is the 922 translocation of the Philadelphia chromosome, where you produce the BCR-ABL fusion gene. And that gene codes for tyrosine kinase that's always on. Okay, it's kind of like the... who's that one? I don't know. It's like Chris Traeger of the of the genes. It's always on, constantly, never shuts off. The BCR-ABL fusion gene 922, it just doesn't ever stop. So it's like John Wick. The gene codes for tyrosine kinase is always on, and it sends signals to divide, grow, and avoid death. And then it just is like, not gonna stop. But there's a solution for this. Imatinib, and it's a tyrosine kinase inhibitor, and that blocks the abnormal signaling at the source. And so here they're asking us, the treatment is expected to interfere with what? constitutive signal transduction. Imatinib is what we're giving them. All these other things are just kind of misnomers or less relevant. Dang, dude, I'm sorry you had dengue. That's crazy. Dengue is no fun. How high was your temperature? Hey, Moise, how's it going? Good to see you.
The lab work points to chronic myelogenous leukemia. One of the main treatments.
The Philadelphia Eagles, says Suleiman. 101? Oh my gosh. That is no fun. I'm sorry you had dengue. I'm glad you're still with us, my guy. Holy mackerel. Well, maybe we should talk about dengue for question 78. Would that be fun? Let's talk about dengue, shall we? So, somebody in our community had dengue and they had a fever. They had 101 temperature. So let's talk about dengue, shall we? Let's make a little step one, everything you need to know about dengue. I think I had a video about this like way early on, like 5 months ago on the channel. But basically, the big thing to know about dengue is there are 4 serotypes that you have to be aware of, right? Den, V1 through 4. And an infection with one gives lifelong immunity to that type, but not the other type. So Moise got type 1. That means later he's going to get type 3 and 4 and 5. No, I'm just kidding. 2, 3, and 4. Bro, gotta give it 26. Oh, man. So you can get reinfected, right? The second infection is a different serotype, right? And it triggers a severe disease. This is due to antibody-dependent enhancement, okay? So what happens is it's a febrile disease. That's why I asked like how high his fever was, and he said 101. Usually you have a very high fever, and it can also present with retroorbital pain and some severe muscle and joint pain as well. They call it the breakbone fever. The breakbone fever, headaches, rash, all that stuff. And so recovery phase, which is probably where Moise is at right now, where you get the reabsorption of fluids, right? The rash can return. There's the white islands of the Sea of Red. White Islands this year. So just look out for that breakbone fever, the intense myalgias, and the arthralgias. And also there's the positive tourniquet test. That's petechia from the capillary fragility. And the White Islands on the Sea of Red is going to be the convalescent rash and the retroorbital pain. Did you have any eye pain with movement, Moise? I'm very curious. If you moved around your eyes, did it kind of hurt? And the hemorrhagic fever as well. So platelet dropping, bleeding gums, epistaxis, GI bleeding. Did you have any of those symptoms as well? But the platelets that you look for when you're treating somebody with dengue is going to be thrombocytopenia. Look out for the low platelets, elevated hematocrit. That's due to the plasma leakage. And also the transaminases are going to be elevated as well, and the positive NS1 antigen in the early diagnosis. So typically, as a first infection, antibodies neutralize the virus, and you just like recover. Yeah, your eyes were hot. Okay, that makes sense. And then the second infection with a different serotype. So they like asking about that second serotype and how that facilitates the viral entry into the macrophages through the FC receptors. And yep, it's antibody-mediated enhancement. That's the tie-in. And so Moise is saying that his eyes were like super hot, like hot. Okay, so let's talk about why that would happen. So retroorbital pain behind the eye, especially when you're moving them, people would often say it's like, oh man, I got this pressure or this heat or sharp pain. Well, that happens because you have systemic inflammation. You have a cytokine storm. So dengue virus is literally triggering massive cytokine release. And so you get cytokines. Which ones? IL-6, TNF alpha. They cause inflammation in tons of tissues, including the extraocular muscles, also the periorbital tissues and the small vessels behind the eye. All those guys. So the inflammation leads to pain and a sense of pressure when you're moving the eyes around, much like orbital myositis. Very similar to that. Yeah, Moe says hot. Yep, I hear you. So the vascular permeability behind the eye is interesting, right? Because dengue is known for its capillary leakage. And so this can cause the edema and the increased pressure in the tight anatomical compartments like the retroorbital space. And so that pressurized space behind the eye results in that sensation of the deep burning pain, especially when you're moving it around. And then the high fevers as well can amplify the pain sensitivity too. And that could, include the sensory nerves that are right behind the orbit, and that's kind of generally part of that hyperalgesia form of viral infections. Oh my goodness, you lost 6 kilograms? Wow. Yeah, that's fair. But just look out for that pain behind the eye, the fibromyalgias, all that stuff like really points you to dengue. And also the loss of appetite it can be common too. I don't know if you had nausea and vomiting. I don't know if this is TMI. Your brother had it too. That's so sad. No, or generalized malaise. All that stuff can present. But even just like short term, probably just the reduced calorie count and the febrile, nature of the disease in the recovery phase. It'll all contribute to the net kind of weight loss. Yeah, I'm sorry to hear that. But capillary leakage, that's the mechanism, okay? So that's question 78 is dengue. So that was interesting. Well, here's the bottom line of our other one that you didn't finish about the Philadelphia chromosomes for BCR, ABL tyrosine kinase inhibitors, target constitutive active signal transduction, and chronic myelogenous leukemia. CML, chronic myelogenous leukemia. I like to remember the CML reminds me of NFL, and then that's like 922 is like a jersey number, and then it's the Philadelphia Eagles. So, just like Sulman said, the Philadelphia Eagles.
The lab work points to chronic myelogenous leukemia. One of the treatments.
All right. So now we can actually just ask. We'll just examine this. Examine this question as if it's our patient. So here we go. 3, 2, 1.
Lab work points to chronic myelogenous leukemia. One of the main treatments we use is a pill that blocks the BCR-ABL enzyme, the abnormal tyrosine kinase driving the disease.
What exactly does blocking that enzyme?
All right, imatinib is what you give. There's your AI patient. Hopefully that was enjoyable. There's the bottom line.
As well as they.
High yield topics before MBME 26. Maybe like Bruton's agamoglobulinemia. I don't know. Everything is just kind of important. Let's see. Maybe look over just the drugs and bugs. Make sure you have all those down pat. Maybe some of the, I remember there's some derm questions that were trickier on MBME 26, but you'll be just fine. I wouldn't try to like prepare ahead of time for it. Just go do the best you can. Yeah, we're wishing you the best of luck, my friend. All right, good luck, Louise. We'll see ya. Take care. 68-year-old woman is evaluated in the emergency department for sudden onset of severe headache, dizziness, and blurred vision. She has a history of chronic hypertension and takes lisinopril regularly. Physical examination shows that she has a blood pressure of 210, and the physician decides to administer a medication that will rapidly reduce the patient's blood pressure through vasodilation. Medication converts to an active form of the body that subsequently interacts with an intracellular receptor to exert its effects. In which part of the cell does this take place? What do you think? All right, so we have rapid vasodilation in hypertensive emergencies. That's nitroprusside and nitroglycerin, right? Both of these guys are going to release nitric oxide. Nitric oxide diffuses in the smooth muscle cells and activates guanylyl cyclase, which is an enzyme receptor in the cytosol. So the answer is the cytosol. Our answer is the cytosol. Is it hydralazine? Yeah, I would think of nitroprusside or nitroglycerin. There it is. It really couldn't have been hydralazine because hydralazine does not act through the nitric oxide or bind to the intracellular cytosolic receptor. Hydralazine directly relaxes the smooth muscle, not via nitric oxide. The exact mechanism is unclear, actually, for that hydralazine, but it's thought to inhibit the IP induced calcium release in the smooth muscle, which then increases CGMP, secondarily, not through nitric oxide. But yeah, it actually acts on mainly on arterioles and has reflex tachycardia and also maybe lupus-like syndrome as well to be on the lookout for. All right, so vasodilators like nitroglycerin act via intracellular receptors, primarily in the cytosol, to rapidly reduce blood pressure. All right, so here is our patient. And let's remember, she is 68 years old and she has some severe headache, dizziness, and blurred vision. She took some lisinopril and she has a really high blood pressure right now. And we're trying to reduce it. And they're asking about the mechanism. So here we go. All right, there's our patient. And so, in what part of the cell does the interaction primarily take place? The answer is the cytosol. Cytosol. Because we're giving sodium nitroprusside for a hypertensive emergency, and it's metabolized to nitric oxide, which diffuses into vascular smooth muscle cells and activates soluble guanylate cyclase, which is an intracellular receptor enzyme that's located in the cytosol. Very cool. All right, so here we have a 45-year-old woman who's referred to the nephrology clinic after elevated blood pressure and microscopic hematuria are found incidentally. CT scan shows multiple large cysts in both kidneys. Her father died of end-stage renal disease at 65, but her mother, same major age, has normal renal function. Genetic testing shows that mutation, PKD1. What describes the variability among family members? Well, we know this is autosomal dominant. Variable expressivity. Indeed is the correct answer. Same genotype with different phenotype sensitivity. You have to know this is autosomal dominant condition. Okay. Okay, hopefully my microphone was working the whole time. I'm just now realizing that this scene might have been muted. But yeah, variable expressivity explains differing clinical presentations of PKD1 mutations in affected family members. Was my microphone on? Oh man, if it wasn't, that'd be so sad. Looks like we accidentally downloaded a random video. Let's watch it. Wow, that was fantastic. Oh, my script downloaded a random video on accident. Well, 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 what can you do? At least we know the bottom line. All right, here is the correct one. So just to remind you guys, she's basically a 45-year-old woman, and she is referred to nephrology clinic after elevated blood pressure and macroscopic hematuria are found incidentally. She's got some large cysts in her kidneys, but her father died at 65, and she has the PKD1 mutation. Let's listen in.
5-year-old woman is found to have high blood pressure, microscopic hematuria, and elevated creatinine. Imaging shows multiple large cysts in both kidneys. Genetic testing reveals a PKD1 mutation.
There we go. Variable expressivity. The voice is kind of strange. Okay. Interesting. How is it strange? I'd love to know. I wonder if there's a way I could salvage that. All right, we're going to do one more question for sure. And then I'm going to go off and code some of this on my own. Question 80. It's going to be nice when this is like fully polished, you know? Like when I can just, boom, have all this stuff ready, immaculate, working so nicely. That'll be the day. Yeah, get some rest indeed. It's 3 a.m. over here. Last question. Last question. So, yeah, let's dive in and do it now. All right, so we have a 68-year-old woman with poorly controlled diabetes, presents with fever, night sweats, productive cough. Dullness to percussion and decreased breath sounds. Cavitary lesions with airfill in the left lower lobe. And labs or leukocytosis with neutrophil predominance. Okay, interesting. So she's 68, and I think for this question, I'll make one up here. What they're going to be asking is, which of the following processes is most likely occurring within the central cavity of the lung lesion? What do you guys think? Is it going to be antibody opsonization with B lymphocytes? No. B cells produce antibodies. Opsonization helps with phagocytosis, but that's not involved. Is it going to be the phagocytosis and free radical generation by macrophages? No, it is not. Macrophages are in chronic inflammation and granulomas, not the purulent abscess. Is it neutrophil mediated enzyme release and bacterial cell destruction? Yes, it is. Yes, it is. All right. Involved in lung abscess formation, those neutrophil mediated enzyme releases. How about proliferation of the epithelial cells? That's seen in healing. How about cytotoxic activity of CD8 positive T lymphocytes, seen in viral infections? So the answer is C for this one, question 80. So bacteria reaches the alveoli via aspiration or hematogenous spread. And neutrophil flood the area, and you get enzyme release and cavity formation. Haha, like this. Neutrophils nibble, necrose, and form pus. It's abscess and liquefactive necrosis. So it's those neutrophils. It's those neutrophils. All right, now let's have this last video generate. And once this last video generates, we'll play it and we'll go to bed. Yes, Sadal got it. Neutrophil predominant cells and liquefactive necrosis, 100%. Thanks, K-Doc. I'm sorry you guys could probably tell that I'm pretty exhausted. It's 3 a.m. over here. Waking up around 9 or so. But I just really wanted to do a couple more questions with this stream because it's just so fun setting up all this stuff with the AI images. Hey, it looks like that one actually worked. It's so variable. You never know if it's going to work or not. All right, so here's the bottom line. This one always works. Cavitary lung lesions and diabetes often indicate pneumonia with neutrophil-mediated bacterial destruction. All right, very cool. Do you guys like this feature over here? as opposed to my laptop camera. Because I was thinking I could have another scene which has just my laptop camera, and then it's like scene, you know? Like maybe this one right here. Not sure. All right. We just got to keep refreshing this until it actually gives us the most recent. Oh, I'm glad you think it's improved. And thank you. Yep, we be out here trying, right, Sidal? Thank you, Sidal. I appreciate it, man. Thank you. You too. Right back at you. All right, here we go. Here's our patient, and let's just refresh ourselves on the lowdown here. 68-year-old woman, poorly controlled diabetes, fever, night sweats, and productive cough. And she's got some dullness to percussion. And let's just listen to what she has to say, shall we? This is your patient.
A 68-year-old woman with poorly controlled diabetes presents with fever, night sweats, and a productive cough. Examination and imaging reveal a cavitary lesion in the left lower lobe.
Cavitary lesion in the left lower lobe. All right, the lower lobe, you're going to have an abscess, and it's going to be necrotizing infection of the lung parenchyma. So there we go, guys. Hopefully you have enjoyed your 10 AI patients of the night. This has been a fun stream, and I hope to just keep polishing this up as I continue to code and improve the stream. So thank you guys all so much for joining. And yeah, it's always a process, but you guys are amazing. So thanks so much. Couldn't have done this without you guys. I really, really appreciate it. Amazing community. So hopefully you guys have just an awesome night, and wishing you guys the best of luck. And we'll see you in the next stream. Adios. Que le vaya bien. Chauzinho. Nos vemos. And if you're watching on YouTube later, then like and subscribe.